Hello, everyone. Thank you for joining us here today. I'm Fabiana Baquin, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate Canadian families of premature babies. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. Also on our website, canadianpreemies.org, parents will find all kinds of resources and support. And today we are going to talk with Dr. Marc Beltempo about the importance of data and its role in improving outcomes of preterm babies in Canada, and how important it is to collaborate, measure, compare, and share with all stakeholders in order for preterms to continue to thrive in Canada. Here is Dr. Marc Beltempo. He's a neonatologist and scientist at the Montreal Children's Hospital. He's the Associate Director of the Canadian Neonatal Network, as known as CNN, and co-chair of its database and annual report committees. The Canadian Neonatal Network is a group of Canadian researchers who collaborate on research issues related to neonatal care. The network maintains and holds a standardized NICU database since 1995 that is used by a variety of Canadian researchers to improve neonatal care. Dr. Beltempo's research focuses on evaluating how the organization of work affects outcomes of infants and identifying best care practices to improve care. Using clinical and administrative databases, he's studying the effects of different healthcare delivery models, resource allocation, and interventions on quality of care and efficiency in the neonatal intensive care unit. The main objective is to improve quality of care and improve efficiency in the delivery of care, a very important work. Dr. Beltempo, thank you so much for joining us here today. I'm very honored that you were joining us from Montreal this afternoon, actually.
Thank you so much, Fabiana. I'm just so happy to be here and share with the community.
And thank you all of you for watching us here today. Dr. Marc Beltempo will present. He has a slideshow to share with us, and then we have a few minutes at the end for Q&A. So you can feel free to share and send your comments on the area below. So Dr. Marc Beltempo, I'm sharing your screen here. You can take over now.
Just confirm before I start that you see my slides now?
Absolutely.
Perfect. Again, I just want to thank so much the Canadian Preterm Babies Foundation to be able to share this and talk about big data for tiny babies. So maybe just first as disclosures to mention that I do receive support and funding through different organizations, which include the Canadian Institute of Health Research, the Quebec Fonds de Recherche en Santé, the Montreal Children's Foundation, the Ministry of Health in Quebec, the Canadian Neonatal Network, and the Canadian Preterm Birth Network. That being said, today, what will we be talking about? Well, mainly what is data? And what is the Canadian Neonatal Network's role in the data management? And how is your baby's information being collected? And why that information is so important for him or her and the rest of the community? And what the role of data is for improving outcomes? And lastly, tell the story of the numbers and not just the numbers themselves. So to do that today, I figured we could take a trip back to the future. So we are in April 27th, 1994 in Montreal, Quebec, and I do acknowledge that I was not practicing medicine back in those days, so I was not the physicians back at that time, but Angelo was born. Angelo was a 24-week baby. He was a triplet. And then back in 1994, the physicians, the nurses, the parents, the babies themselves are asking themselves, what are the estimated outcomes back in 1994 for that baby? Well, back in 1994, a 24-week infant had about 1 out of 2 chances of surviving neonatal care and actually being able to go home. And out of babies that were admitted to neonatal intensive care units back in 1994, only 2 out of 100 would actually survive the whole hospitalization course without acquiring one hospital complication, or what some people will call a morbidity. So back in those days, people were asking probably the same questions we're asking ourselves now. Is that a good outcome? How do we get that information? Is it even accurate information that we're reporting? Can we do better? And if so, how do we do better? So from those questions comes a big statement known in health economics and in the industry, which is basic, which is if you can't measure something, you can't improve it because you don't know if what you're doing is working, not working, or even getting things worse. So that illustrates the importance of having accurate information or data. So that's where the Canadian Neonatal Network came in. It was founded in 1995 by Dr. Shu Li, who I believe presented to the community last December as a keynote speaker. It originally started with 16 units that decided to participate. But as of today, all of Canadian level 3 neonatal intensive care units are participating in this network. So we've managed over time to regroup all of Canada within this umbrella. And what does the Canadian Neonatal Network do? It essentially and mainly collects data on all preterm infants less than 33 weeks that are admitted to those hospitals. And that includes information on the pregnancy, why prematurity happened in that situation, what were the interventions that were given to that baby at birth, during the hospitalization, and what were the outcomes of those babies. And the Canadian Network is not just a few people that decided to get together, it's a whole community. And there is oversight through a governing board. There's an acting director, which is currently Dr. Prakash Shah, the associate director, which is me. There is oversight through an executive committee. Most of the activities and the data management is done at Toronto at the MyCare Center at Mount Sinai, where there's a team of analysts, database experts, which maintain and analyze the data, which is done in collaboration with each of those 31 sites across Canada. So why are we focusing most of the network's energy on the infants less than 33 weeks? Yes, we do include all preterm infants that are admitted within those units, but a lot of the focus is going into less than 33-week infants because these are the infants that are at the highest risk of either dying during hospitalization or acquiring morbidities during hospitalization. And when we talk about morbidities or complications, we know that each of these increase the lengths of stay. They not only increase costs for the hospital, for families, and for society long-term, it also increases the stress for families and the risks of long-term developmental challenges for these infants. But when I say the word morbidity, what does that mean? Well, typically internationally, there are certain morbidities that have been recognized as measurable and comparable between units and countries and that have internationally recognized definitions. So the reason is, one of those is retinopathy of prematurity that you may have heard of, which affects the eyes and it can affect the long-term vision of the babies. There's bronchopulmonary dysplasia, or what people will call BPD, which affects the lungs and can affect the long-term lung health, which can turn into long-term asthma or even restrictions during exercise or hospitalizations for lung problems or fragility. Another one is infections that I believe Dr. Eugene Ng presented a few weeks ago also, which again is associated with long-term challenges and short-term complications also. The other one that we follow is intraventricular hemorrhages, or what some people will call IVH, which is essentially bleeds in the brain of the preterm infants, mainly because they're very vulnerable to fluctuations and interventions that can affect that. And also we know that intraventricular hemorrhage, or IVH, is associated with higher risks of having long-term challenges in their development. And lastly, we look at necrotizing enterocolitis, a complication that affects the guts due to immaturity. And again, that can eventually lead into major complications with need for surgeries and also affects long-term development and the gut health of these babies. So why these 5 outcomes and why mortality also? Yes, a lot of biological factors affect these outcomes that can't be modified. For example, there are differences between boys and girls, between different gestational age, the weight, if the mom had diabetes or hypertension, can all affect these outcomes. But we also know that how we care for the babies can affect the outcomes. And this can range from interventions that we do prenatally during the delivery, how we ventilate the babies, how we feed them, how we position them, the type of medications we use, including antenatal steroids, or even hand hygiene policies in neonatal intensive care units. Skin-to-skin care with parents and parental presence are all factors that affect these outcomes. And how we do this affects the trajectories of care. And that's why in each of the 31 NICUs in Canada, you have people reviewing the charts of all of these babies and filling in data collection forms online and uploading the data. But is this data safe? Are we being careful and are we following all the stringent rules? Yes, we are. First, each hospital has to approve the data collection. So that means either having a research and ethics board and a quality improvement committee that allows us to collect this. And they review us every year to make sure that we're following those rules. Most of those committees have issued what we call waivers for individual patient consent. So typically in most units, parents will not be asked to sign, are we allowed to collect the data? Mainly because all that data becomes anonymized. So once the baby's information is logged or inputted into the database, nobody can track you down to say, well, this baby, this is what happened. It's all anonymous at that point. And then the data is held in a secure database, which follows the stringent privacy laws of each province in the country. So what happened to baby Angelo? Well, baby Angelo then became baby 2081. And a diligent data abstractors in Montreal fill these electronic charts for each of the days he was in the hospital, what type of interventions he had, and what were his outcomes. And then baby 2081's data was then uploaded in the CNN database. And that data was sent to the coordinating center in Toronto, where all that data was put in together and analyzed for the country. And what did baby 2081 teach us at that point? Well, the first important thing that we learned through these babies in the first generations of the database was that there was a lot of variations in outcome between hospitals in Canada. In a theoretical, ideal healthcare system, everybody should be doing well and everybody should be at the top. But what we realize is that even for major outcomes like the rates of bleeds in the brain or intraventricular hemorrhages, back in the mid-90s, there was a lot of variation. So here you have on the x-axis the 16 original sites that were participating in the database, and on the y-axis you have the rate or percentage of babies that had intraventricular hemorrhage in each hospital. And what's striking when you look at this is, for example, the first site, N, on the far left, had almost 60% of its babies having at least IVH during hospitalization. Whereas if you look at the far right, site M had less than 15% of their babies. So we're talking about a fourfold variation between two different sites. So this is not just the biological factors that explain this, it's how the sites were treating their babies. And this created an opportunity for site N to learn from the other sites that were doing better. The other thing we eventually learned over time and realized that in Canada is that between 2006 and 1996, there were little changes in outcomes, despite all the efforts of everybody in the community. So here we have on the first column the outcomes. The second column, you're looking at the percentages of infants with each of the individual outcomes in 1996 compared to the third column, 2006-2007. So what you see here is that the rates of bronchopulmonary dysplasia or lung complications increased from 34% to 46%. And that the rates of brain bleeds was not decreasing over time or intraventricular hemorrhages, it was actually increasing. So that mobilized the whole community because people thought, well, just by providing regular care, things will improve over time. They weren't. So that forced people to say, how can we improve data and improve quality of care, which is the biggest question. And what is quality improvement? It can seem like a simple idea, which is consistently doing the right thing for the right patient. But that's complex, because it also involves implementing better evidence, better practices in an ever-evolving world. And the biggest challenge is, even if you know what you're supposed to do, it involves so many stakeholders. One simple example can be, we know that breastfeeding from mom's fresh breast milk is better for babies. How do we get the mom to pump, to give the milk and provide it to the baby in a timely fashion? All those interventions can involve multiple stakeholders. For example, like I talked about breastfeeding, it ranges from involving families, antenatal care teams, postpartum, physicians, nurses. And when it comes to using drugs or different respiratory interventions, there are also other stakeholders like pharmacists, respiratory therapists, nutritionists, etc. So getting one thing right can involve a lot of people, and that's where it becomes complicated. And that's why improving quality or improving care is a continuously ongoing process. It's always dynamic. So here you have an illustration of what is quality improvement. It's a constant uphill battle. But to win that uphill battle is these small cycles, these small objectives. So what will people call PDSAs in some language, or plan, do, study, act cycles, where you say, okay, over the next 3 months, let's focus on trying to increase our support for breastfeeding for moms. And we want to check how many babies are able to get mom's breast milk. And we're going to develop a program, have a lactation consultant, and do sensitization and teaching also to parents and to the other healthcare professionals. You evaluate that. Did it work? If it didn't, you learn from that and you find solutions and you continue going uphill. And the key here is that it never stops, because you always have to sustain and motivate people for change and improvement. And that's why the evidence-based practice for improving quality, or what people now call EPIC, was developed, which is a Canadian collaborative project. So it's an ongoing collaborative of quality improvement program that was formed to improve care practices and outcomes specifically for neonates. And now includes all 25 level 3 NICUs in Canada. And what this program does is, first, there is in-person learning sessions. So we give people the tools on how to lead a project and a team for quality improvement. The second big thing is, it's not physician-led, it's not nursing-led, it is interdisciplinary. So everybody is involved in this process within each hospital. And the big key about site variations, what we talked about earlier, is that we're matching sites that are doing better with outcomes like BPD with other sites that are doing less well in those sites, so that we can learn mutually. And that other sites are good at infection prevention while other sites are struggling. What can they learn from each other to try and improve everybody together? And that's the same reason, for example, me in Montreal, I could learn from people in British Columbia, people in Alberta are learning from people in Nova Scotia, all that with the single unique goal of trying to improve how we deliver care. And that's what's been going on in Canada since now almost 2003 till 2021 now. And these are the 3 main projects that occurred throughout this process. And every time we change our approaches to try and keep up to date with best practices. And has it worked? Well, one of the key things we've seen is from 2004 to 2017, here on the x-axis is time, and on the y-axis is the rate of babies that received antenatal steroids before they were born. At the beginning of this, antenatal steroids, we knew that it not only increased lung development, protected the brain, and improved survivals of babies that are able to get them before delivery, but in 2004, only 3 out of 4 babies, so 75%, were being exposed to that prior to delivery. Through repeated interventions, repeated processes, we've managed to improve that to almost 90% in Canada. And this is one among several practices that have been successfully implemented and sustained. And that's been translated in Canada into better survival without major morbidities for each gestational age group infants. So here is something that we published last year, going from 2004 to 2018. And on the y-axis, what you'll have is the rate of the outcome. So for each group, so in orange, you have infants born at 23 to 25 weeks. That increased from almost 5% up to almost 18% now of infants are able to survive without acquiring major complications. It almost quintupled the improvements in outcomes. And where we've seen the biggest improvements were amongst the smaller infants, 26 to 28 weeks with the green line. And you saw the same trends for infants 29, 30 weeks, and 31, 32 weeks on the top in blue. So maybe all those improvements in outcomes were everywhere, and it's not just Canada. Maybe other countries were doing the same. Well, thanks to data and information and having standardized definitions, we're able to compare ourselves to other countries. And what you see here is 2007 to 2014 rates of death or major complications in 10 developed countries with comparable data. So in 2007, if you go at the top in red, this was Canada. Out of the 10 countries in 2007, we were the worst place for babies to be born preterm. If you look at the effect of time and participation in collaborative quality improvement, and you follow that big red line, you can see that Canada is actually now in the top 3 places if you are to have a preterm infants where they'll have the best chances. So does this mean we've made it? Not completely. But what's important to learn is that over the past 14 years, the outcomes of preterm infants in Canada are consistently improving, and that this is different than other national networks in other countries. Mainly, we are the only network that has engaged in a data-driven national quality improvement program. And I think the take-home message here is what I've been saying a bit since the beginning, is that there's no magic bullet or magic drug that's going to change the trajectory of our infants and how we deliver care in Canada. And in the last 20 years, there have been only a limited number of interventions that have single-handedly improved major outcomes for preterm infants. It's been the combination of things and consistently integrating better evidence in the form of bundles to try and improve brain health, improve lung health, improve gut health. And that's why standardizing care within the units is the key. And to do that, you need to have the information. And what does this mean for families and babies? Well, right now we're continuing on implementing and sustaining new evidence-based practices as the science evolves. So whether this can involve promoting and implementing feeding protocols on when we start feeds, what type of feeds should be used, the implementation of donor breast milk to allow time for the mother to eventually produce her own milk for the baby, but to be able to at least provide donor milk instead of formula to babies. Supporting mothers to breastfeed by providing benchmarks to units and better practices, changing how we ventilate babies. And monitoring the impacts of these practices changes in real time so we know what worked in which unit. So what does real-time feedback to units on processes means? So right now through the database, in real time, units are able to see how they're doing compared to the other units in the country to say, well, is my rate good enough? Am I doing better, or can I continue to improve? And who can I identify and look to improve? So this is just a screenshot of the report we produce annually, where, for example, a site can see how many of their babies were exposed to antinesium magnesium sulfate. So we give that to the mothers before delivering preterm, and we know that that reduces the risk of cerebral palsy long term. So when you have sites that you have rates of 85% and 93%, you can think you're doing well. But the question is, what can the lower sites that have 50% learn from those better sites? And same thing for other interventions. One of the recent successes has been, for example, the implementation of deferred cord clamping, or what other people will call delayed cord clamping. So when the baby is born preterm, if you wait for a minute before cutting the cord, we know that that helps the heart adapt better. It can help the brain adapt better and reduce the risks of bleeds, and even has benefits for the gut also. But that involves a whole group of key stakeholders, ranging from obstetrics, the neonatal team, the resuscitation team, and the family, to let them know that for a minute, we will be looking at the baby, monitoring the baby, but not cutting the cord. And we're one of the countries that has been able to implement that faster than most. And here we have from 2013 to 2017, how Canada's went from almost 50% of our babies receiving that intervention to almost 70% in 2017. And this again has been done through regular feedbacks and collaboration across hospitals in identifying what works where. So what does the future hold? Well, we have to go beyond looking at outcomes, yes, no. We have to start looking at trajectories of care. And that involves going beyond yes, no outcomes, which are just, do you have BPD, yes or no? We know now that BPD, for example, lung complications is not just something that is there or not there. All our preterm infants have longer term risks, and we have to assess that and follow that with families. And that's why there is also the follow-up network that looks at long-term outcomes and follow-up. Also, there's the whole question and important issue of family support, and particularly discharge planning, and looking at where these babies are being discharged from when they go from level 3 to level 2 units, for example. Which brings us back to baby number 2801. What happened to him? Well, he actually had two siblings, babies number 2802 and 2803. His two siblings, unfortunately, did not survive back in 1994. But all three babies were included in over 50 publications that helped identify better care practice, motivate change, and provide accurate information on outcomes to help inform policymakers, families, hospital physicians, and healthcare providers, and to continue to improve neonatal care to this day. And also, baby 2801 continues to change neonatal care. He went from being the data to actually helping improve care for others. He became a physician who actually has been doing research with the Canadian Neonatal Network database. And last year, we published this paper on looking at the cumulative effect of evidence-based practices to reduce the risks of brain injury in extremely preterm infant. So in conclusion, numbers tell an important story. Canada has a unique database that has stimulated change and improvements over time. And without data, we don't know what we are doing, and we don't know where to go. I just want to thank everybody for their attention, and also thank the Preterm Birth Foundation for the opportunity. Thank you so much.
Thank you, Dr. Beltempo, for your wonderful presentation. So important, the work that you're doing and the whole network. So we are very grateful. I also want to thank everybody for joining us here today. We have people from Saudi Arabia, Mexico, Alberta, Argentina, and Toronto. So we have a great audience from everywhere. So thank you so much for joining us. If you have any question for Dr. Beltempo, now is the time you have for you to ask those questions. But Dr. Beltempo, I have a first question for you. You mentioned that CNN collect data for all 31 level 3 NICUs in the country. So for the babies who get transferred to a level 2, do we still collect the data on those babies to see the outcomes once they leave the level 3 hospitals?
I think that's one of the major challenges we have right now as a Canadian community. The Canadian network does not have access to that data because there's so many level 2s. I think we're talking about 100 level 2s in the country. So that's a lot of babies and a lot of places to follow their trajectories of care. So we've unfortunately not been able to get that information. There are other organizations that have partial information on them. And I think you're talking about the biggest issue, because once we move babies to a level 2, what happens after that? How many are readmitted? And there's a whole family experience of going from one specialized center that's doing things in a certain fashion to going to another center that's doing things in a different fashion. And that can create anxiety for families and even for the babies themselves that have to go through that whole process.
Absolutely. So we talk a little bit about the neonatal follow-up. Are we collecting data from the neonatal follow-up? Because perhaps you miss the babies on level 2, but then they come back to follow-up clinics on the level 3 center where they were. Do we have that information on how well they are doing post-discharge?
Absolutely. So for the subgroup of less than 29-week infants, so this is not the complete all less than 33-week infants, so we are missing some infants. But for the most vulnerable ones, the ones born less than 29 weeks, those babies are all followed in specialized clinics in Canada that are part of the Canadian Neonatal Follow-Up Network that has standard evaluations at 18 months, fills their data, and is linked to what we have with the Canadian Neonatal Network database. So again, in Canada, we're in a unique position where we have this, at least not complete trajectory of care, because after 18 months, we don't collect all that information, but we at least have those first 18 months of life.
Which is very important, at least
which is critical.
Beginning. So many other countries, we know they don't have that data collection opportunity. So they don't really know what happened to those babies after.
And beyond that, I think there's the whole, I've been talking about quality improvement, but there's the whole notion of also patient safety. I mean, for most families that have been through the neonatal intensive care unit, I've seen novel things being done, drugs being used at certain doses that are all appropriate, but that people are not 100% sure what's going to happen 18 months later. So what we're able to do with the database is linking all that information and having information almost in real time saying, well, we have signals that this is better than A is better than B. And we're able to feed that back to people and inform the community to take action when we need to.
So that leads me to ask you, so do we have standards of care? Because if we know this happens in one place and doesn't happen the other place, and the outcomes are better on the other place, does this database help us to standardize care in Canada?
So it helps us homogenize care at least a little bit. There are officially in Canada no standards or no lists of standards of care like there are in Europe. Into, for example, this should be in each unit. For example, these resources should be there. There should be protocols for all of this. What we do in collaboration with units is we build lists, or what people call bundles, of best recommendations of what should be done for baby to improve lung health. And each hospital adapts that to their reality. Because one thing we know with the network is there can be different ways to do the same thing. So you can choose different methods to use ventilation for a baby. What's most important is that within that unit, they are consistent. Because sometimes there's no big difference in the outcomes of two interventions. You can use, for a CPAP, for example, a special mask, and other people will use a special prong. It looks completely different for a family that's going through that process. But what's important is that the unit where you're at, they know how to use the technology they have in that site, and that they're doing it well.
Oh, that is so important, because sometimes families get very anxious knowing that one hospital is doing this way, the other hospital is doing that way. But it's really to reassure the families, the hospital they are at, they are good at what they are doing.
Exactly. And again, we know that because working in tertiary centers, we work with level 2 units that have, sometimes it's small details, going from different size or different colored tube feeds. And then the family's been used to that same type of tube, but both are equivalent. But what's important is that you use only one type of tube in your unit, not different types, and that you're doing it right in your hospital.
Okay, so my question is, because families now are more informed, there is more information available. They can Google and find all sorts of information from anywhere in the world, but practices are completely different than the ones in the hospital here. But if you focus on the Canadian research, families do have access to some of the CNN data because it's an open website. How easy is it for families to understand the data to make informed decisions with the medical teams?
Yeah, I think the biggest point is always communication and transparency between families and the team and the medical team. And when families have those questions, they have to bring them up with us, and it's our role to kind of put that into perspective and bring that to context. The website and the data can be overwhelming, and I acknowledge that. I mean, sometimes it's heavy to look at, but I mean, when families have questions, it's important to bring them to us, and it's our responsibility to answer them to the best of our abilities or to refer to people that can answer that. And again, to put that in perspective, that you can have two different ways of doing a similar care, but what's important is developing protocols within the hospital so that the whole team is able to do it consistently.
Absolutely. But Dr. Beltempo, also, I would like to reassure families that what happened to one baby not necessarily is going to happen to the other baby, because sometimes it's so overwhelming to listen to this information for families, especially if they are in the ICU or if they are 1 year post-discharge, still wondering what's going to happen to their babies when they reach the toddler years. So as my personal experience as a mother of preterm baby, I know that outcomes are different for every baby. We have the data, but we don't know the trajectory, the care at home, the follow-up, all have influence on the outcome.
And I think the end of my presentation sums it up. It's the story of numbers. It's not about the numbers themselves. And I mean, we can talk about statistics for years, but at the end of the day, a baby is a person, and that person is not 80% BPD. That baby is not BPD, yes, no. I mean, it's what is the impact of that on that child's life and that family's life? Whether we're talking about cerebral palsy, whether we're talking even about a normal development long-term. Some children may have different challenges. And what is the impact on that family? So I think, I mean, we're the first people to try and step away from those numbers. We need these numbers to try and do quality improvement and drive changes to a certain extent. But when talking to families, the biggest thing, and for families also to realize that your baby is not a statistic in itself.
Absolutely. Thank you so much for that, Dr. Beltempo. I'm very grateful for all the work that you do and for all the CNN network, amazing work in Canada that you're doing. We are so grateful. And I know the meeting is coming up in February. We're looking forward to participate on the meeting as a parent organization once again. So thank you.
And thank you to you. And we're just grateful to have families on board with this type of project. So thank you so much for the support.
Thank you. Stay with us. I'll be just wrapping up. And thank you everyone for watching us today from all over the world. We are very grateful to have your presence here with us. You can make suggestions of other topics you'd like to see here on our live. And the video of today's session and all the videos from our past Facebook Live series are available on the CPBF website, which is right here, CanadianPremis.org. We are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all NICU families. And I see you again next Friday, 1 p.m. Eastern Time. Thank you and stay well.